Before I decided I will make this instrument, I worked hard for about 6 months. I had no patients. I lost all my patients because I became president. Every time they come, Oprah, he has traveled out, they will say, they will send them away from the gate itself. Mat aao, wo nahi hai aaj. So 15 times you travel to Delhi, patient will get fed up and they don't come. So once I finished the presidency, I had no work because all my patients had disappeared. Nevertheless, I thought, okay, let me decide and invent something new in strabismus. I worked in strabismus for 44 years of my life. So if I don't leave anything which is useful in strabismus, and my name will never be remembered. So I put it initially as Santhan's magnocellular stimulator. I said, that is very egotistic. Remove your name from that. So I removed it and made it as orthoptech, where we use technological knowledge to straighten the eyes. That is the definition of orthoptech. So let's see how it works. Before I go into the detail, let me get my Before I go into details of how it works, why it works, certain basic things are very essential. You need to know the definition of amblyopia, process of vision, current management, and future management of amblyopia. What is the old definition of amblyopia? Difference of two lines. Is it really correct definition? You all know it is not the correct definition, because there are a number of other problems associated in amblyopia, like hyperacuity problems, like space perception problems, spatial interaction, contour integration. So many problems are there. How can you say just difference of two lines between the two eyes is amblyopia? It's a dustbin diagnosis. You cannot diagnose amblyopia based on just checking vision. If he's bored, he will say, I can't see. Then you'll say, okay, amblyopia. It doesn't work like that. So we need to understand neuroanatomy, neurophysiology, neuropathology, and all the ophthalmic skills you need to have to diagnose amblyopia, which is again a dustbin diagnosis. Vision is a dichotomous, complex process starting from retina up to the cortex. There are parallel streams with horizontal connections, and there are top-down and bottom-up impulses. Bottom-up is from retina to the cortex, top-down is from cortex back to retina. Both the impulses are there. And the top-down streams, the impulses coming from cortex, they modulate the bottom-up impulses. So, to give you a small example, you are walking on the street. You see a man coming on the other direction, and you know that you have taken money from him and he is going to trouble you. So immediately the brain recognizes in the peripheral part, something is there who resembles some man from whom you have taken money. The brain immediately tells the leg, move around, move away from this area. So we will turn around and move away. So even before the eye has seen what it is, the brain has given instructions to the leg muscles, move from here. You understand? This is one example. The second example is I went to south of France for a holiday. South of France is a nice place, but a long time ago when I was much younger than what I am now. I went there and we went to beach in south of France. And myself and my wife was there happily, we were walking. I was walking happily ahead of her. And after some few minutes, she said, let's get out from here, let us get. I said, what for? Everything is fine here, why should we go? Then I realized nudist beach. No wonder I was walking happily and she was pulling me, I was going like this. Even though she was pulling me like this, my eye was going like this. So this happens because the brain understands where to send the eye to look at what. You understand? So that is one of the reasons why the bottom-up impulses are influenced by the top-down impulses. Either they can suppress or they can stimulate. Glutamatergic and GABAergic. Glutamatergic neurons are stimulatory, GABAergic neurons are suppressing. Both are essential in life. Okay, this is how it is. They have already shown you all these pictures. For the sensory cortex, a greater representation in the LGB compared to the motor cortex. Okay, and so it is in occipital cortex also. sensory cortex has a sensory part of retina in the center, has a greater representation compared to the peripheral part of the retina. Now, LGB is not a simple relay station. Why am I telling you all these things will become clear in exactly 5 minutes? LGN is not a relay station. Only 30% of the impulses are allowed to go beyond. Remaining 70% are stopped at LGB. So is amblyopia due to problem at LGB? Probably, we don't know. We have never studied LGB in vivo or in vitro anywhere. But we are trying to study that, and we are proving that some cells are, there are various types of cells in LGB, and some of these cells are narrowed in amblyopia. Has it got to do anything with the suppression? We don't know. Okay, so after modification, it allows 70% of the impulses to go to 30% of impulses to go to cortex, suppressing 70% of the impulses. Why is it important? You will know. So this is how it is. Magnocellular, parvocellular cells, magnocellular cells in the periphery with lesser representation in LGB, parvocellular cells in the center with greater representation. The impulses all finally reach from the retina and central and peripheral to V1. V1 is the lowest center. It does not have any analyzing capacity. It's like Manmohan Singh. It just follows the order from higher centers. You do this, you sit down, he will sit down. You get up, then two people come behind and make him stand up. So occipital cortex is exactly like Manmohan Singh. Has no thinking of its own, but it gives impulses to the higher center, saying, boss, you people sort it out and tell me, I don't understand a thing what is coming to me, but this is what is exactly coming to me. It replicates the same stimulus that is coming to retina to occipital cortex in the parietal cortex and in the frontal cortex, and in different parts of occipital cortex it sets impulses. It doesn't analyze the image. So the peripheral retina goes to parietal area aware of vision, central retina goes to inferotemporal cortex, what of vision. But finally they come back to parietal cortex where the attention center is situated. These, for a long time, attention center had not received any importance at all. They didn't bother, oh, forget about attention center. Now, after a lot of research, more than 2,500 papers have appeared in the about attention. What does it do? Why is it important to have attention center? Okay, so where of vision is in superior parietal cortex. That's where the M cells go. And what of vision is in inferotemporal. Every object has 4 important or 5 important features: size, shape, color, texture, movement, and position in this space. Any object, it may be moving towards you or away from you. You may have convergence or divergence. It may be moving to the right or left, lateral rectus, medial rectus, up and up, down. It can move in any direction. So therefore, the replica of where the object moves can be picked up by the brain because of the copy of retina is pasted on the frontal cortex, parietal cortex, everywhere. That's how the brain knows where is what. And that's how the where and when, what are interconnected. The problem with what of vision is it has to analyze the action potentials, which takes time. Time means, don't think of Indian judiciary, 20 years. Brain works in only 20 milliseconds or 15 milliseconds, extra it takes, but that makes a difference. So when the what of vision is actually analyzing the object, okay, impulses from the object, the eye should not move, correct? If the eye moves, it will be lost. So what the brain does when you are concentrating, using the central retina, it's sending impulses to attention center, which sends negative impulses to the saccadic generation center in the parietal area, which sends negative impulses to frontal eye field area. Therefore, the eye does not move. See how difficult it is to understand why the eye does not move when fovea is focusing. We all know the statement, the eye does not move when the fovea is focusing, because Fovea has zero retinomotor value. No. Because the attention center suppresses the saccadic generation center. This is the neurology. Why do we need to understand all these things in orthoptic? Very simple. When you do the orthoptic, the top-down impulses which is stimulating the movement of the, which is generated due to movement of the eyes, comes from parietal lobe, from the superoparietal area, it comes down to the parietal attention area in the inferior parietal lobe. From the attention area, it comes back to occipital lobe and stimulates the foveal area and occipital lobe. And therefore, every time the eye moves, foveal suppression is removed. And therefore, within a few seconds, the vision improves from top-down impulses. Why top-down impulses work? Because the top-down impulses discharge not just in synapse, but discharge beyond the synapse. And in amblyopia, the primary problem is at 4C beta. That's where P cells end in 4C beta. And in that synapse, we have a problem in amblyopia. Also, not only in LGB, but also probably in 4C beta. So what you're doing by giving patching in, this is how the eye looks connection in the brain. Sarvendriyanam, Nayanam, Pradhanam, they said. How the eye is connected to all the structures in the brain. Now you understand the meaning of Sarvendriyanam, Nayanam, Pradhanam. No other structure in the body has this amount of interconnected spaghetti junction connection, what I call, in the brain, except from the eye. So in order to do a good job for amblyopia, you need to do a good understanding of neuroanatomy, neurophysiology, neuropathology. This is a MRI scan which shows how there is no blood supply while focusing with the amblyopic eye. While focusing with the normal eye, the blood supply is like that. And when focusing with both the eye, the blood supply is slightly reduced than focusing with one eye, good eye. Because amblyopia has a suppressive effect even on normal eye. So you are patching the normal eye and stimulating the amblyopic eye, the vision reduces even in the normal eye. So it's important to understand these aspects. You don't need to know neurophysiology, neuropathology and all. As long as you know that the problem in the eye can produce problem in V1 and in extrastriate areas. So what are you doing by patching? Are you stimulating extrastriate area? No. Somebody told us patch, we are patching, and blindly we are patching it for 800 years. We have not changed. Till somebody suddenly realized we are doing something wrong. And Saraswati granted him some thoughts. He said, it may be like this. Think. And I thought, and that's how I designed orthoptic. So if you don't want to know all the details, and you don't want to see this pathetic face of the child with normal eye covered and vision only counting finger in the other eye, please buy orthoptic and treat. Okay? And this is how we do in our clinic. Now this also has changed because of the color I have seen. There is a very complex physiological explanation for that. You don't need to know. And this is how we do. Make them sit, and you can see that even a small child knows how to do it. So how to do it is very simple. The machine comes with adequate instructions everywhere. And we will send you email, and you can phone us anytime as long as I am not eating or sleeping. If you leave a message, I'll call you back. So you can buy for not 1 year. How long have I supported you, Reshma? Whenever you have called, I have supported you. So there we go. I don't say only for 1 year or 2 years. Till you buy and till you are satisfied, we will support you. So indications are very simple. They have already given you amblyopia, bilateral amblyopia, ametropic amblyopia, strabismic amblyopia, and anisometropic, I mentioned, strabismic, and amblyopia exanopsia. I'll tell you why it does not always work in amblyopia exanopsia in a few minutes. We have time up to 125, I think. Am I right? The session is finished, or 125, no? Yeah, session, because I see other people from other sessions already sitting and trying to sleep through this talk. So I thought I'm late. No, I still have 14 minutes. I'll finish much earlier than that. So these are 4 indications. Apart from that, macular dystrophy, which you showed you, and 100% I am sure that it improves. I don't know why it improves. Give me time, I'll tell you why it improves or how it improves. And optic atrophy, yes, it does improve. Nystagmus, it does improve nystagmus in many patients. Okay, but you must understand what is the mechanism in nystagmus. Then you can use it. Okay, if the latent nystagmus, it disappears completely. The reason why latent nystagmus occurs is there is one more receptor which detects the motion detecting receptors. They are absent in the foveal area normally. Sometimes may be present, even if 1 or 2 receptors are present in the foveal area, because they detect motion. And in foveal area there is no movement. So they perceive that why am I sitting here? So there must be some motion. Slowly they move the eye. Suddenly the other parts of the brain realizes, no, there is no motion. Then the eye straightens. So that's how latent nystagmus is. The movement is slow, recovery movement is rapid. With the left eye, it beats temporally. With the right eye, it beats temporally on the other side. So that is why latent nystagmus improves, but not fully, because I think the receptors are still there, which you cannot do anything to them. So you have understood everything. If you have any questions at all to any of the earlier presenters who have done a great job and made my job easy, you can ask me.
I know first couple of sessions slightly differently.
Why Dr. Santhan Gopal is charging so much? It's not for the machine. Machine probably you can do it in a very small amount. It's for the innovation and his thinking and what he has spent years of his effort to devise this instrument.
See, cost is right now 1,32,000 at the moment. But because of Ukraine war, it may go up as well. We also have been affected because of Ukraine war. So it may go up. I am still holding on to it. If I sell it off to a private fellow and say goodbye and take the money and go, he will charge you not less than 4 lakhs. For the same machine, he will charge you not less than 4 lakhs and he will distribute and he will make his money. But I'll take my money and go quietly, retire and don't do all these exercises.
Usually how much charges are taken per session?
Very correct. It depends on you, the pretty optometrist next to the patient, and how much time you spend explaining, etc., everything. But on an average, you can charge 1,500 per session. And they need about 15 sessions to 20 sessions. So about 30,000 rupees it works out. Most buyers have recovered the cost within 6 months. They have recovered the entire cost. Now it is running free for them, but they are making money on that. Okay, that is the economics of the machine. Okay, shall we call it a day? Thank you very much, all of you. Thanks you. 2 to 4 plus tomorrow 10 to 12, there is a DSDC demonstration of the same machine. You can come closer and see and learn a bit more.